All right, everyone, let's get started. Welcome to the Essential Substance Abuse Skills webinar series. My name is Jeff Ladolter, and today we have invited Bob Rorit to speak on professional and ethical responsibilities. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website that you can find in the box below. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Our center is a NADAAC certified educational provider, and continuing education hours are available on request for a $15 fee. A request form is available for download in the Files box in the webinar screen, and I will also be sending this form in a follow-up email to everyone who attends today. Immediately following today's webinar, you are going to be redirected to our GPRA evaluation. SAMHSA asks us to evaluate our events in order to provide improved performance assessment and accountability. And this survey asks about your satisfaction with the event. It will take less than 5 minutes to complete. We thank you in advance for helping us improve our programs, and we really appreciate your feedback. You will be muted for the duration of this webinar. So if you have questions about the presentation or about the Adobe Connect system, please use the Q&A box by typing them into the field at the bottom, and we will address questions at appropriate points during the presentation. You can also use this box to introduce yourself. Today's speaker is Bob Rorit. Bob has worked in the field of addictions treatment for over 20 years and is currently serving as the Executive Director of the Minnesota Association of Resources for Recovery and Chemical Health, and has also been involved in our ATTC as an expert trainer. Bob, thank you very much for joining us, and I will pass things over to you at this time.
Sure. Thank you, Jeff. And please, folks throughout, welcome first of all, and please ask questions throughout this or stop me if something isn't clear, and I'll try and answer it more thoroughly. I needed to update my bio. Not that it matters much probably to you, but I'm currently an administrative manager for Hennepin County in Minneapolis.
Oh, sorry.
No, that's all right. I think the bio needed updating. So anyway, that's my current position, and I primarily oversee addiction reform efforts that are taking place in Minnesota right now and helping the county make adjustments to those reforms. Previous to that, I was the Executive Director for a statewide association representing addiction treatment providers and professionals. And then here in Minnesota, before that, I was director of a large detox or withdrawal management program in St. Paul. So just I say that just to give you a little bit of an idea, the last few years anyway, of what I've been doing. I also worked in Hawaii for a few years, which was wonderful. I don't know if anyone on the call is from Hawaii, but right now in Minnesota, I'm thinking of Hawaii a lot and missing it. Today we're going to talk about, let's see, 42 CFR Part 2 and ethical considerations. So the idea here is to look at how the privacy law and ethics both coexist, but also can create some moments where decisions around the right and wrong thing to do can be a little muddled. The intersection between legalities and or the legal system and ethics can be a little bit confusing, and this whole topic is not something that's real definable. You know, there isn't like a here, do it this way, and it'll work every time. So there's a lot of nuances to everything we'll talk about today. My hope is not to confuse you or go in a direction that's not helpful to you in terms of what you might need to know for a licensing exam or a credentialing exam. But my hope is to give you some perspective, I think, on how to make ethical decisions especially when those decisions are influenced by legal constraints that you might be. So let me just move ahead here, and we'll take this as it comes. Like I said, ask questions along the way, please. Just a refresher, 42 CFR Part 2 is the federal code of regulations that governs addiction treatment programs. It's a privacy law, and it applies to any program whose primary purpose is to provide addiction treatment and the program receives any federal funding of any kind. So that federal law is in place for probably most of you, or I'm guessing most of you, either through your place of employment, if your program primarily focuses on addiction treatment and you receive any federal funding. There were some revisions to the law 2 years ago, I believe, that opened it up a little bit in terms of sharing information, and I'll get into that. But this particular law was created back in the 70s, and it was primarily designed to prevent discovery of people in substance use treatment. So if it looks like this law makes it exceptionally hard for law enforcement or the courts to get information, that's because it wasn't intentionally designed that way. The idea being that if people were discovered in treatment, that is, if law enforcement could find people in treatment and serve warrants or arrest them, then people wouldn't go to treatment in the first place. So that was the rationale behind, at least much of the rationale behind the law in the first place. These are the highest standards of privacy law in healthcare. So these are more restrictive regulations than HIPAA. And if you don't know 42 CFR Part 2, you should study it. There's an electronic version available online. If you just Google 42 CFR Part 2, the electronic version, you should be able to find it pretty easily. I think I covered this. Let's see. So this law and I won't get into a tremendous amount of detail, but this law essentially states that you can't release any information about a person that's in your program, including their name, even if law enforcement requests it, or you get a court order or a subpoena. Still, by law, you can't release any information, including the person's presence at the facility. There are some exceptions to that I'll get into later. But if you keep in mind, I can't release any information without this person's consent, or unless it meets one of the qualifications under the exception. This will hopefully make more sense with respect to ethics as we go along here. So you can also not redisclose information. So if you get info from, say, a hospital or another treatment program, you can't re-release that information without the person's consent. The Legal Action Center on the bottom bullet point here, you did a nice summary of 42 CFR Part 2 and the current amendments to it that were made in 2017. Those almost didn't get passed. I was in Washington, D.C. when they were debating this, and the SAMHSA director was there. She wasn't sure these new amendments would get through, but they did in the last minute. Just quickly, some of the changes that were made include the to whom section of the consent form. Now you can designate more broadly who the information can go to. You can say, for instance, all my treating providers or all providers involved in my care, or however you want to word that. Now, of course, the client has to consent to that, but the effort there is to broaden the scope of information sharing and make it more likely or more easier to do to share information with multiple providers that might be involved in that client's care without violating federal law. And another thing that I think a lot of people don't know much about is qualified service organization agreements, QSOAs. Those are agreements between, say, a treatment provider and some other entity that provides some kind of service that the treatment provider doesn't offer. So it could be something like peer support or case management. If your agency doesn't offer those services, but another agency close to you does, you could have one of these qualified service organization agreements with the other agency and share information freely once the agreement's in place. Again, the other organization would then be held to all the privacy law requirements under 42 CFR Part 2. Programs now must also list or provide a list of all other people or agencies that you release information to if the client requests it. That's kind of important to know. If you don't keep track of that and you happen to get, I don't know, subpoenaed or something, well, you have to provide that information. You'd be hard pressed to do it if you haven't been keeping track. You have to go back and look through records and all that fun stuff. There's one way law enforcement can gain access to your records. There's a specific court order that law enforcement can seek, has to be signed by a judge, has to be, if they're seeking information on a client that might be at your facility, it has to be in relation to a serious crime, and there has to be no other way that law enforcement can obtain the information other than by coming to you and getting it from your records. That court order signed by a judge has to be accompanied by a subpoena, and the subpoena is what compels disclosure. So the court order itself doesn't compel you to do anything, but the subpoena would if both things are present, right? So if law enforcement shows up at your door 1 in the morning, like they always do, and they say, we know so-and-so is at your facility, and we need to talk to them, and I have right here, I have a search warrant, or I have a subpoena that says I can go into your facility and get that person. Legally, they cannot, right? So legally, they have to show up with a court order and a subpoena, and it has to meet these other standards before they can gain any access to your facility, or before you can even tell them that the person is there. So you have to say, I can't confirm or deny the person's there until you have these documents. That's important because ethically, your responsibility is to protect one of your responsibilities ethically is to protect the privacy of your patient. So if law enforcement shows up and you don't know these things, you just assume it's okay to let the cops in because they have a search warrant, actually violating a federal law, but you're also not advocating for the client in that respect by protecting their privacy. So that's why I'm focusing on this particular aspect of right now of confidentiality, because it is one of the ethical principles that you need to keep in mind as you work with people in these facilities that are covered under this law. So a court order and a subpoena are required, and it has to be in relation to a serious crime. There has to be no other way that law enforcement can get the information other than by coming to you. I hope that makes sense. The only other way to release information is if the client signs a consent form, or if there's a medical emergency. Obviously, you can call 911 and give the paramedics the necessary information that they need to treat the person. without a consent. And then child abuse. Child abuse is obviously you're a mandated reporter, but if I were to give advice on this, I would say consult with a supervisor if at all possible to see if um, the the child abuse concerns are valid. And that is, are you sure that's happening, or is this just something you're hearing? How do you determine if this is a valid child abuse case, or that you should report it outside of the realm of 42 CFR Part 2? I'm not saying, the child's in danger, of course you report it, but if you're not sure if there's vagueness in terms of the report, then I would always consult with the supervisor. So we'll get into ethical considerations here in a moment. I would like to back up just a bit, since this is a webinar on ethics. And one of the things I was going to talk about today, just a little bit, to ensure that you at least know what I do in terms of where this profession is headed. I wanted to give you an example of this won't necessarily affect your ethical decision making, but it does apply to your professional considerations going forward. And I think it's important to pass this along. This profession is changing dramatically, and you probably know that. Here in Minnesota, for instance, we're in the midst of implementing, like I said, addiction reform efforts that were passed by the legislature that are really an attempt to move addiction treatment into the realm of healthcare, where it belongs, actually. So, as a professional, when we think about client care, the connection here to ethics that I'm trying to make is, when we think about client care going forward, we're going to think about client care in the context of their overall health. This profession is going to eventually integrate with the rest of healthcare, and we will be a part of healthcare. How that will change some of these privacy law requirements is yet to be seen. But the idea here is that we now recognize addiction treatment as a healthcare condition, a chronic healthcare condition that involves physiological and behavioral components. So what we're looking at doing here in Minnesota, for instance, is broadening the scope of what addiction professionals do, how they interact with other healthcare, and moving things like withdrawal management or detoxification into that realm as well, which these kinds of things have always been sort of separated and marginalized in terms of the healthcare world. So as we think going forward, you're thinking about the well-being and care of the client. Of course, you're going to think about all of the things that are encompassed under addiction counseling. But you're also going to want to be aware just more broadly of how decision-making, ethical decision-making, and care decision-making are impacted by the fact that we're looking at addiction treatment differently than maybe we used to. So getting out of the mindset of this is a specialty service that I have to stay within these narrow guidelines as far as my scope of practice goes, thinking more broadly about how do I interact with the rest of healthcare in a way that's beneficial to the client, most likely will result in better health for them. I don't know if that connection's clear or not, but I'm trying to establish a mindset that we're not in the addiction treatment world of 20 years ago. We're moving into a different realm. We have to think differently, not just about privacy laws and ethics, but about how we fit into the scheme, the larger scheme of healthcare as a profession. And then that was a terrible segue, but I'm kind of moving in now to some of the dilemmas that can arise currently when the privacy laws conflict with morals, values, and principles that you might hold as a clinician, and how to think through some of those dilemmas. Again, always use a supervisor. I mean, decision making in this area can be very tricky, and if you aren't careful, even if you think you're doing the right thing, you might be stepping over the line in terms of what the law requires. So, generally speaking, if you're making a good faith effort to help somebody, you're not going to get in a lot of trouble, but that's not a hard and fast rule. So always consult when you can. I realize there are times when that's not possible, in which case my default has always been to do what I thought was in the best interest of the person I was serving. Um, the issues of beneficence and non-maleficence are really, beneficence is really trying to improve the client's situation, add to the benefits received by the client. Non-maleficence is doing no harm. And those are the general principles when you're talking about ethics that you're trying to abide by. So you're trying to do no harm and at the same time trying to find ways to benefit the client and add to their health and their well-being. Fidelity and responsibility can be thought of in terms of being trustful or building trust with a client, the therapeutic relationship, and applying those same principles, ethical principles, to each client the same way. So there's fidelity both in terms of your honesty and integrity, and there's fidelity in terms of how you apply those things across the board, even when your personal beliefs might interfere with, your opinion of that person. I think integrity is a key to really a successful career. If you admit when you're wrong or you don't know something, if you again apply the same standards to everyone regardless of your personal opinions. These are very difficult things to do because we all have personal opinions about right and wrong and what our culture or our society believes are right and wrong, and trying to weigh those things on top of our personal beliefs to make a good decision on behalf of a client. Now, it might be a client you don't especially like, or you don't especially like what it is they've done in the past, but applying those same principles, those same standards to everyone is critical. Social justice is another issue. I think it's just justice here, but advocating for social justice, advocating on behalf of your client. Oftentimes, the people that we serve have no voice or don't know how to express themselves. We have to be there, so their advocate and apply social justice concepts to everything that we do. And of course, respect people's rights and dignity. One of the things that you may have come across too is I'll use an example of detoxification or withdrawal management. When I ran a program in Ramsey County, there would be people that would come in there for admission, sometimes every day, sometimes more than once in a day. They would leave, they would get intoxicated, they would come back. Part of that is a commentary on how broken the system was. But what I wanted to focus on here was that when people did come back regularly, there was a tendency on the behalf of some staff to sort of refer to them in a derogatory way. Here comes so-and-so again. Nothing's going to help them. It's a really dangerous trap to fall into, and it's easy to do. But when we talk about rights and dignity, we have to remember that these folks that have become sort of recognized as regulars or chronics, as some people will say, have lives. They've had childhoods. They've had oftentimes careers, education. They've had families, most of them. They have histories. And I think what's really beneficial and what will make the biggest difference in outcomes for people seeking help is to recognize that, acknowledge that, and take a little time to listen to everybody, and make your own uh, reserve your judgment of them, uh, not not casually referring to folks like this as a burden of some kind. And that may not have been the intent when staff did that, but that was the message that was conveyed, either explicitly or implicitly. I just say that because it comes up a lot, and I really, that would be a time when I would get a little angry, and I would say to the staff person, listen, you really need to remember this is a person who needs help. They didn't need help, they wouldn't be walking in our door every day. And the fact that they come in here every day says that they find something about us valuable. So let's use that to our advantage in helping them find a different path. Um, that relationship with clients is more critical than any behavioral theory, any I think any other aspect of treatment. If you can form some sort of genuine connection with the person, treat them with dignity, and listen to their beliefs around that are developed either through culture or their own personal beliefs, and understand them without dictating or trying to impose your own beliefs on them. Boy, that will get us further, I think, than just about anything in terms of maintaining some kind of relationship with that person through good times and bad, and keep them connected with healthcare. The important thing here is to keep the person connected with healthcare, regardless of what that looks like. That in itself will extend life and hopefully lead to a happy outcome. I think here are just some examples of codes of ethics that you can refer to. I don't have any doubt that the people listening right now have a sense of what ethics are, and you've probably attended, multiple trainings or webinars around ethics. So there's probably not anything that's, going to surprise you when you look at these codes of ethics. You wouldn't be in this profession, you wouldn't be doing what you do unless you had a sense of right and wrong and wanting to help people. What we hope to do when we do these trainings or these webinars is to just, I think, what it helps me with is just to kind of fine tune or provide some maintenance for ongoing practice, so you kind of remember things that maybe in the course of your career you haven't talked about much. So it's just kind of a reminder of here's things to focus on, here's things to remember about ethics, and here's what you do if you don't know what to do. I don't know that there's much difference between these codes of ethics. There may be subtle differences, but they all pretty much say the same thing. Do no harm and try and benefit the client. Obviously, you're going to avoid things like relationships with clients. You're going to avoid things like any kind of monetary exchange with a client. Anything that would be considered a dual relationship or a conflicting interest. Your only purpose really is to objectively help that person make the best decisions that they can to improve their health and to abide by the law. One thing that we don't focus on enough, and in future webinars I'd like to work with the ATTC on how to do this better, is to more closely focus on how ethical considerations are made when someone of another culture enters a treatment environment. Most of our treatment environments in this country are designed around Western-based thinking. So we have this medical system and these behavioral health systems that are primarily designed for middle-aged white guys like me but they don't fit. But oftentimes, people from other cultures or with different belief systems don't fit well within these Western-based models. So, what we need to do better as a system, and I think there's some work being done on this, is to say if we design a treatment system, a treatment program, how do we design it in a way that reflects both an acknowledgement of other cultural beliefs and values, and how do we apply the kind of care that we're providing in a way that matches those values and beliefs. Native Americans are obviously a group that, when I've worked with Native communities, have a different way of thinking about what healing is than we might. That is, we as a Western-based provider. And we do a terrible job, I think, in general, of listening to those other cultures and listening closely enough so that we understand, okay, if we adapt what we're doing to accommodate those beliefs and values, not just accommodate, but to respond to those beliefs and values differently, we may do a better job of providing a kind of care that makes sense to those populations. We had, as another example, we had ran some statistics about the populations that were being served in our facilities. This was, again, at another employer. And we saw that Native Americans were overrepresented in terms of the opioid epidemic. That is, more Native Americans were affected by the opioid epidemic in terms of percentage, but fewer Native Americans were actually being admitted to treatment environments. To me, that's just an obvious example of people, Native American folks aren't going to treatment. There's a reason for that. And one of the reasons, at least, is that the type of treatment that we're providing doesn't match what those folks were looking for in terms of help. And until we adjust and become more flexible around state statutes and treatment regulations, until we open the door a little bit and say spiritual healers are equally qualified as maybe another professional in terms of providing some type of care, then we're really hindering our ability to serve people, not just from Native American communities, but from other cultures. We have to have a broader sense of people see health and wellness differently, and they view solutions to health problems differently than Western culture does. So, some work's being done on that, but I don't think, a 3-hour course on cultural awareness is going to cut it. I think we have to build it into a system, a treatment system, and into the funding mechanisms that support those treatment systems. So that was, I'm sorry, got on my soapbox. That's cool. Always a good idea to keep the client alive. Anything that might, any other considerations might be thrown aside when you're faced with a life or death situation. So I would always do the thing that keeps the person alive and worry about the consequences later, thinking primarily about an emergency situation in a treatment environment. I mean, whatever it is you have to do, naloxone or call 911 or CPR or whatever, but just keep the person alive. You can't treat them if they're not alive. There's a duty to warn that it can come up, and ethically it can be a challenging thing to deal with. It might seem on the surface that a duty to warn is a pretty clear responsibility. If you fear somebody else is in danger or the client's in danger, then you report it. But you really have to be kind of careful about at what times a situation raises to the level of a duty to warn. If somebody came into your treatment program and they said, I'm mad as hell, and when I get out of here, I'm going to blow up the city of Minneapolis. Is that really a situation where you're required to warn somebody? Generally speaking, a duty to warn would apply to a specific threat to a specific person or people, or a group of people. But it would have to be, you'd want to think about, I would think, first of all, is this something that realistically this person could do? And do they have a way in which they could accomplish this? If you're not sure, again, I would talk to a supervisor or a colleague or whoever you could. And if you're erring on the side of caution and you're not sure, then probably a duty to warn would be advisable. But my point is, sometimes clients will say things that are simply not within their ability to do. They're not going to blow up the city of Minneapolis, or they're not going to, I don't know, do some other a thing that you're well aware they can't. They don't have the means, or they don't have the skill or whatever to do the thing. Plus, who would you warn if it's a broad warning like that? If it's a broad threat like that, that kill everybody when I leave here. Well, who the heck do you warn? I guess the fallback is if you think the person's a danger, a true danger, and they could harm somebody, then you would want to err on the side of caution there. I think some of these things are pretty self-explanatory. Don't use clients for your own personal gain, financial, physical, emotional, whatever the gain might be. Our job is not to benefit from the clients; it's to assist them with the health challenges that they're faced with. And I always emphasize consult, because I've been in situations where I thought I was going to do the right thing until I talked to somebody else, and then I realized what I was going to do wasn't probably the best course of action. So, ethics is messy. I included just a couple of slides from NADAAC on a few of the principles that applied to confidentiality. As I said earlier, confidentiality is one of the things that you're responsible for when you're making ethical considerations. I won't go into this in any more depth. Just read or at least look through 42 CFR Part 2 at the different categories or the different headings, and read up on anything you're not familiar with. And do pay attention if you go to go to the Legal Action Center website, or just Google 42 CFR Part 2 Legal Action Center. They provide a nice summary of what the changes are to the federal law. Just checking to see if there's anything else here we really need to discuss. One other thing quickly is when you're looking at privacy laws in the state, uh, your agency, the state, and the feds all have different privacy regulations. You always go with the federal law in that case. The federal law takes precedent over state law. It takes precedent over, obviously, agency policies. So if you have a state law that says you can release information under a particular circumstance, but the federal law says you can't, you have to go with the federal law. Whatever law is more restrictive, you follow. All right. I'm just going to kind of skip through these. Can I take just a minute? Does anybody have any questions? No, I kind of meandered all over the map there, but so far, does this make sense? Does it not make sense, or is there anything else that I could expand on? Jeff, just interrupt me if there's questions that I'm not seeing. All right, just a couple of examples of potential ethical dilemmas that might involve you or your some situation you encounter in your agency. I know everybody hates it when you read slides, but I'll read this one. You meet with a client that tells you that he was involved in a series of robberies, some that involved serious assault, in order to obtain money to buy drugs. The client said he was never caught, laughed at the fact that he got away with it. What would you do in that case? Just think about it for a couple of seconds. In other words, would you report that to the police? Would you not? What would you do? Well, the answer is you couldn't report that by law to the police. By law, that is by a federal law, if a client told you that 10 years ago they killed somebody and they were never caught, this might be one of the upcoming questions, or they committed any kind of a serious crime in the past, by law you're not allowed to report that to the police. If it's not something that they have done while involved in your program, or if it doesn't involve a threat, an immediate threat to somebody else or themselves. Ethically, that's a tough one. Again, it's where your personal beliefs or societal beliefs bump up against privacy law. So we kind of covered this, but a police officer arrives at your facility late at night with a search warrant, demands that you let him or her in. The officer says, I know the person is there. This has happened more than once, where police have shown up at a program I was operating, and they said, hey, we dropped this guy off. We know he's in there. We need to come in and talk to him. You can't, under law, unless this person signed a consent form to the police, you can't acknowledge that he or she is in your facility. You can't, unless they come back with a court order and a subpoena, and it meets all of those requirements under 42 CFR. Even if they know they're there, you can't tell them they are. Client gets in an argument with another client. Out of anger and frustration, one of the clients picks up a chair and throws it at the TV in the client lounge, destroying the TV. Is this something you could report? Yes, because it's a crime that was committed on the premises of the treatment program. Any crime that's committed on the premises of the treatment program can be reported without consent, and the person can be charged, including destruction of property. And this is the example I used earlier. By law, you can't report that to the police. It seems counterintuitive, but that's just the way the law is written. So this one's sort of a no-brainer because I already answered it. If the police show up under these circumstances and all the paperwork, the court order and subpoena are in order, yes, you could give them access to the client and acknowledge the person's there, of course. The best way to do that is to, if you were faced with a situation like this, would be to have the client come to a separate room and then wait, and then have the police come in and take them into custody, away from the other clients, away from everybody else if you can. So in this case, if a client has a seizure or some kind of medical emergency, of course, you can call the paramedics, call 911, and give them just the information they need in order to treat the person. or whatever information they need to treat the person. Okay, so this one's a little tricky. If the police come to your facility and they say, we're looking for so-and-so, and we believe they're in your facility, and we need to see them. If you know the person is not in your facility, can you tell the police that? Can you say, this person's not here? The answer is yes, you can. If you know the person is not in your facility, you can tell the police that person is not here. The reason for that is it prevents the police from going through this sometimes lengthy process of getting a court order and subpoena only to find out the person was never there to begin with. It doesn't do much for public relations with law enforcement if that happens. So the idea here is to acknowledge, no, the person's not here, but not give the police any additional information if you know it about the person. So you can say that person is not here, and that's all you can say. Now the police get wise to this if you encounter them enough. To where if you say, I can't confirm or deny the person is here, it's a pretty good indication the person is there, right? Because they understand that you could tell them if the person wasn't there. So, they kind of give you a wink and a nod, but you still can't divulge that the person is in your facility. You can only say you can't confirm or deny that they're there. And the overall goal is, again, for confidentiality, is to protect the public, the counselor, the profession, the process, the integrity of the process, and the client, of course, from discovery. Oftentimes, if you tell the law enforcement, you say, can't confirm or deny the person's here, but I'll go check. If they're not here, I'll tell you. And if the person's there, you go back and you say, look, the police are here. They have a warrant for you. You can either deal with it now or it'll catch up with you later. If you give us consent, we'll let them know that you're in the facility. If you don't give us consent, we won't confirm or deny that you're here. Sometimes the client will make the decision, I'll just deal with this now and get it over with. And they'll give consent. But oftentimes they'll say, I don't want them to know I'm here, and you have to honor that. No, I guess this was a multiple choice. The answer is protecting the client. You have to pick one. The goal of ethics, then, like Jeopardy. Actually, the goal of ethics is to protect the profession, the integrity of the profession, and principles that guide the profession. You, of course, also protect others and these other things in the process. That's the overall goal of ethics. Now I'm hoping maybe some of you have questions or comments. I can respond to those. I'll give you a couple minutes here. And Jeff, do you see any questions or anything from anyone?
It doesn't look like we have any questions yet, but if anyone has one, please feel free to type it in the chat. We can address it.
While I wait, I just wanted to go back to the topic of the changing profession a little bit. And I wanted to give you at least an example of what we're trying to do here in Minnesota. Our legislature in 2017 passed what was called substance use disorder reform. And substance use disorder reform involved the inclusion of things like treatment coordination or care coordination, peer recovery support, and what's called a comprehensive assessment, all of which are now billable under Medicaid. This, again, was part of an effort to create an avenue for this profession to blend better with the rest of healthcare. And by doing that, the understanding and the effort was to say, if we're to be a part of healthcare, we need to be funded and supported in a similar way as other healthcare is funded and supported. So Medicaid expansion efforts were an ideal way to include some of these services that were formerly, at least here in Minnesota, not billable under Medicaid. Now, I know a lot of states have done this, so I'm sure we're not unique. But the other main component of these reform efforts was to look at how do we view, as a profession, how do we view client health? Is it a case where you treat one aspect of a person's health, their addiction, or treat their mental health concerns separately, or their physical health concerns separately, and then communicate about those things? Or is it better to treat the whole person? By treating the whole person, I mean look at more broadly not just their health concerns, but their environment, their employment, their culture, and other things that would influence the way they view the world around them and the way that they view their health and solutions to their health problems. So we get a more of a public health kind of model that's being developed here that looks again at how do we more effectively engage people so that they take an interest in their own healthcare, and whatever that engagement consists of, peer support, some sort of less intensive treatment option, whatever that person's willing to engage in. Here in Minnesota, they have the option of doing that. So somebody had a comprehensive assessment, and that assessment indicated that the person probably should go to a higher level of care like residential treatment. But the person says, I'm not willing to do that, or I can't do that because of my employment or my family or whatever the case may be. The client has the option of saying, I'm not willing to go to a residential facility, but I will talk to a peer, or I will engage at an outpatient level and try it out. The reasoning being that engaging that person at any level of care is more beneficial than either forcing them into something they don't want to do or making decisions on their behalf. It ties in with motivational interviewing, and it ties in with public health concepts around behavior change. If you can engage somebody at whatever level of interest they have, they're more likely to stay engaged with healthcare over time. And then you can use peer support and care coordination beyond their treatment experience if they do that to keep them engaged. It's really not a whole lot different than what we do for other chronic disease like heart condition, diabetes, asthma. You treat the acuity of it as best you can, but the patient really has the decision-making power as to how they want to engage in that health. That's the model we're trying to move towards here in Minnesota. I think it's a better way to go, and I think it's a more reasonable way to go. If we're not engaging people in this business, if we're not finding ways to connect with them, then they're going to avoid us, and they're not going to get the help that they need. Medications are also an important part of this, and we're looking at how we can support and implement medication-assisted treatment options like Suboxone or Vivitrol, naltrexone, if that's an option. But the idea here again is to look at the medical and the behavioral aspects of this illness the same as we would any other chronic disease. There's behavioral components to just about any chronic disease that would improve health, and there's medical treatments that would be beneficial in most cases. So. Okay, I've kind of talked myself out. If there are no questions, I don't really have anything else to add. Wait, see a question. So Kate has a question, a couple of them here. Kate has a question. Just for my own curiosity, are providers expected to keep all of clients' information private from other clients? Are names or first names allowable? Technically, you're supposed to keep all patient information private, so from other clients. Now they're going to discover things just through interactions, but as a professional, your job is not to share any private information from one client with another client. Lynn had a question: how are the privacy laws different from minors? That's a good question. Actually, that's left up to the states. So here in Minnesota, boy, it's been a while since I worked with minors. So here in Minnesota, I believe that the state law requires that we contact a guardian or a parent if a minor presents for care. In other states, like when I was in Iowa, minors had the same rights to confidentiality as adults did. So if a minor came into treatment, a substance use disorder treatment service, we couldn't inform the parents of anything, including their presence there, unless that minor gave us consent. And I think that's still the case in Iowa, but I'm not sure. So that part is left up to states. The general rule is don't release anything, but if the state law says you have to, in the case of minors, then you have to. That's a good question because earlier I said federal law always sets the precedent. In this case, federal law left it up to the states to make that decision. If the question is, do we follow HIPAA or 42 CFR Part 2, you always follow the confidentiality law that's more restrictive. In most cases, 42 CFR Part 2 is more restrictive than HIPAA. Whichever law is more restrictive, you follow the more restrictive path.
Hey Bob, this is Kate. I had another question real quick. Have you found, as you're talking about the shift in behavioral and mental health being incorporated into the healthcare in general, do you see changes in how MDs are being trained or just their perspective as far as like what parts of this is in their purview? I'm thinking kind of an example of my own situation of going to see a medical doctor for really a mental health issue and not having really been referred before to a mental health professional or something. I'm curious if you're seeing that start to change as well.
There is movement. I can speak more specifically to Minneapolis or Hennepin County. The Hennepin County Medical Center has an addiction medicine clinic. Dr. Gavin Bard is the medical director for that. And where I've seen the integration starting to occur between like addiction medicine and behavioral health, more traditional kinds of behavioral health care, is in the area of medication-assisted treatment for opioids and alcohol. There are still part of the problem, I think, with respect to the integration of these disciplines, is that one is financially. The funding mechanisms are so different that you can't always arrange care in in all of these settings or with all of these professionals because of the differences in the way the client's care is funded or not funded. So it's hard to bring multidisciplinary groups together when they're saying, how are we going to get paid for this? And unless there's a mechanism to do that, it's difficult to do. But most medications for addiction treatment, as far as I know, like Suboxone and Vivitrol, are reimbursable. And that's an area where addiction medicine has really, at least here in Minnesota, has made an effort to incorporate or work with behavioral health programs that provide addiction treatment and to incorporate MAT into those programs. For an example here, there's a couple of mobile Suboxone clinics that will come to behavioral health settings and set up clinic there to induce people on Suboxone or maintain their Suboxone. And Vivitrol is another area where some of these programs are starting to offer Vivitrol as an option for mostly alcohol, unless a person's had the ability to withdraw from opioids for a period of, I think, 5 days before they can take a Vivitrol injection. But these medications are, I think, of vital importance, and it's figuring out right now. What we're doing is figuring out how to get these systems to talk to each other and how to reimburse for the time and costs that are involved in in integrating systems, and that's a really challenging thing. Just quickly, the problem here with Vivitrol, it's reimbursable by Medicaid, but programs have to purchase the initial dose, and it's like $1,000 a dose. So they, addiction treatment programs don't have a lot of money on hand to buy initial doses of Vivitrol. Once they provide it, they can bill Medicaid, but there's a lag time, and they don't have the budgets to do that. So there's a disconnect sometimes between the funding source and the need. Well, here's a tough question I might not be able to answer. What is the difference between 42 U.S. Code 290DD-2 and 42 CFR Part 2? I don't know the difference because I don't know the other code. I would just say that if you look at 42 CFR Part 2, it would seem to, at least in my reading of it and my understanding of it over the years, it would seem to supersede any other code with respect to patients in those environments. So if a person is in a program that primarily provides addiction treatment and they receive federal funding, 42 CFR Part 2 would seem to be the code that would supersede other privacy or confidentiality codes. Now, I'm not a lawyer, so that's my interpretation. Anything else? Is there anyone else that has a question or would like some clarity? I didn't want to focus too much on the going through codes of specific principles of ethics, because I think you probably already heard that a million times, and I don't mean to say it's not important, but you can certainly look at any code of ethics and read it yourself without me reading it from a slide. So my hope here was to apply ethics to it and privacy law in a way that was maybe, I don't know, maybe hasn't been done too often in ethics seminars or trainings. I have one more person typing something here, and I don't know what time do we end, Kate and Jeff.
We can go as late as 1:30, so we have plenty of time. But if that is all the questions that we have today, we can wrap up. I want to thank Bob Roard again for presenting this, and I want to thank everyone on the call for joining us. As soon as this meeting ends, again, you'll be directed to our GPRA evaluation site. We would really appreciate if you took the time to give us your feedback. It would take less than 5 minutes. and it would help us continue to bring webinars like this to you. Bob, is there anything else you'd like to say?
Jeff, it looks like one person is typing something. Can I hang on just a second to see if I can answer that before? Okay. I'll give them a second here. Oh, the question was: is there a is the training recorded? Or I think they are.
Yes, we will make this available on our YouTube page, and we will send out a link to the recording as well.
Okay. Well, then I think that's it. You know, I appreciate you taking the time to listen to me ramble on, and I hope you all have much nicer weather than what we're expecting. Yeah, have a good day.
All right. Thank you, everyone.